Okay, great. And so I'm going to do a quick recap of what we're doing here today. I know it's going to be the same information several of y'all have already heard, but for those of you who haven't heard it, it'll be exciting and brand new. So today is the final of our 4 office hours sessions. So this office hours event, it's a brand new addition to the annual restatement process. It's part of the commitment we've made to this year's legislative session. And this is a learning opportunity. So we don't have it perfect, and we will definitely be seeking feedback when we're all done and ask for improvements on how we do this next time around. And I want to note also that this is pretty unstructured. It's an open conversational opportunity. We're looking for collaborative discussion between CCOs and OHA about the significant change proposals we have on the table for 2026. And reminding folks too that our shared interest is pursuing the solutions that are the best interest of our shared OHP members. So we're going to get in the weeds, in the details, and we have an hour and a half to cover 4 topics. So I think we should have plenty of time. And what we learned today is going to help us refine the proposals when they are eventually submitted for formal approval internally. So, and if I could ask an OHA colleague to take care of admitting folks into the room, I would really appreciate that. So going to our next screen here. So we have 4 changes on deck, as I mentioned. So one is a required change. That's number 1 on the list here below. And then we have 3 discretionary changes. So what we're going to do is poll our CCO colleagues to see which ones they most want to talk about. And then we will discuss them in priority of those with the most interest. If the poll doesn't work again this time, we'll just do a simple hand raise. And so what I have also in this document that I'm using on the screen and also that I attached the invite is the past CCO presentation slide decks for each of these. And what I'll be doing is going to the page in each of those decks that describes the change so that folks have it in front of them for easy reference. And I've confirmed that all of our colleagues from OHA who are the proposers, they are in the chat. So I'm going to go ahead and launch the poll. And if it's not working for folks, let me know right away so we can abandon that and move to just simple hand raises. Take a moment to load. That doesn't load well. Okay, so we're going to launch it right now. So we'll give it until 9:40 and then we'll close the poll. It looks promising. We have 12 responses so far. Thank you, Shelley. And thank you, Dave. Okay, well, so it looks like the poll was more successful than last time, but still not working for a lot of people. So we got 24 responses. And let's see here, error message, will it work? Oh, that's a bummer. Well, so what the poll is showing me, I'm going to just make a note real quick here. So one. Okay, so then I'm going to stop the poll. I'm going to do a quick hand raise, okay? So I'm going to, okay. I'm going to stop the poll. And so let's do a quick hand raise. So what we're going to do is have only our CCO colleagues raise their hands. OHA folks, don't raise your hand. And so for folks who want to discuss the BHP topic, raise your hand right now. Just going to look at the counts here. Okay, we're going to close the BHP topic. So it looks like we have 11. We have 11 for BHP. Okay, so put your hands down. And now we're going to go to the share topic. And so raise your hands anew if you want to talk about share. Okay, so we're going to close that now. And so put your hands down and then raise your hand anew if you want to talk about NEMT. Okay. Okay, and then hands down and raise your hand if you want to talk about the Health Equity Plan NCQA topic. Okay. Then hands down. So we have in priority order, we have HEP, NCQA, then NEMT, and then share, and then BHP. So I'm glad I did the hand raise because that is a little different than what the incomplete poll results shared. So we can put our hands down unless you have a question before we start. So Mary or Jacob, do you have a question? Or just a lingering hand raise?
Sorry, lingering hand raise.
Yeah, just lingering hand raise.
No worries. Okay, thank you so much for bearing through that. That worked out okay, actually. So, and what I want to do now is actually have our colleagues involved with the health equity and NCQA proposal join the call, get ready to talk. I'm going to go to that slide real quick. A moment. Okay. So on the call, I believe I saw Maria. And I'm looking to see if Chelsea is on the call. Yep, there's Chelsea. So Maria and Chelsea, why don't you introduce yourselves real quick?
Sure. Chelsea, do you want to start?
Sure. Chelsea Guest, CCO Finance Director.
And Maria Elena Castro, she, her, your pronouns, Health Equity Innovation and Implementation Manager at the Equity and Inclusion Division.
Thank you both. So given that this is an open discussion, how we're going to handle this is that folks can raise their hand and I'll call on you to speak and then we'll just have the conversation. And I will also pay attention to the chat for any questions and I'll try to call them out for Chelsea and Maria to respond to. And so we'll continue on this topic for a while. And if it looks like there starts to be a lull in the conversation or if it's taking a whole lot of time and we've not, it doesn't look like we'll have enough time for the other topics, then I'll kindly curtail the conversation. But with that, folks can start raising their hands. Dave.
Hey, nice to see you all again. I think that there's a lot of kind of places to start, but maybe I really enjoyed our discussion in contracts and compliance, so I don't want to rehash that, and instead would love to kind of talk through the requirement of achieving accreditation and that timeline. So I think the top of mind for me after our conversation on Tuesday was timeline and cost of achieving the accreditation. And so based off of kind of my research and project planning around the elements and the process of accreditation, I'm concerned about potentially achieving even if we're starting now, there is a non-zero probability that accreditation couldn't be completed just from a process standpoint by December 31st. So I propose some language around initiating or making meaningful progress as a replacement for that date. And then that also takes away some of my fears around the external uncertainty that surrounds potentially federally governed or funded bodies and what the federal administration may ask or require of them that might change things midway. But anyway, I can take all of that anxiety and put it to bed if we have some different language around making progress rather than completing it. So I'll just pause there in case others want to discuss that point too.
Maybe I'll just jump in. So really appreciate that. I have gotten a little bit more feedback since Tuesday as well from the side related to some CCOs estimating 18 months to achieve, being more also just understand that some of the CCOs are more complex and larger, and it may have more organizational hoops to jump over versus smaller CCOs. So I do think the 18 months is unique to the CCO that I talked to. May not be for everyone, but we do have a variation in size and complexity within our CCO model. And so I think having some conversations, I do emphasize that we were planning on having some exceptions for case-by-case basis that feels like that. But I do agree that maybe some language that's more focused on what we would push forward and making that, what is meaningful progress. I think that's where we could work through and maybe even get there. I do think progress would probably not receive and this is where I want Maria to jump in, but progress would probably not take away some of the requirements in the health equity plan. I think the accreditation is going to be more of that drop on the administrative burden in the plan submission. But I think meaningful progress would keep you, in this out of a deadline issue. So I think there's probably a little bit of a give and take there. But I'm open to Maria's thoughts if she doesn't agree. I know we were trying to get to more of a goal or a deadline with some exceptions, but putting some language in there, I'm not personally against, and definitely want Maria to jump in.
Thank you, Chelsea. No, I mean, first of all, let me be very clear that what we put out there is a very, very high level piece of information. This, of course, needs to be worked out. Some details, need to be added. And so I appreciate the concerns, and I don't have a problem with it. One thing I do have a problem with, and I know you didn't mean it this way, but I just want to make sure that we are all clear that while we don't know what the federal government will say in the future and what words we may or may not use, being able to use, we can't use diversity and things like that. Whatever word that we have to use, health equity is at the bottom of the work that we do. I mean, it is the work that we do. And we work with a population that has faced significant barriers and will continue to face significant barriers. So we may not be able to call it health equity. Whatever happens, I'm talking about a future where we are not even be able to say a phrase, for instance, that claims health equity. But I just want to make sure that you all understand that whatever shape or name we have to use in the future, the intent of our goal of eliminating health inequities by 2030 will remain firm and strong. And we hope that And I know that many of you would agree with me that should be the end goal. That being said, we will face challenges, and I understand concerns, and I will do anything in my power to ease those concerns. This is one of the reasons why we decided to develop an educational glide path, if you will, so we can support CCOs that were concerned. They didn't know where to start. They didn't know exactly who to talk to. So we are open to all this feedback and open to make it work for all of you. So yes, happy to address those and find a solution that works for all of us and work for the member as well.
Now, Marie and Chelsea, I want to call your attention to Josh's comment in the chat before we go to the hand raises. So could OHA share with us how this change will reduce other reporting requirements? If this is still the case, could the OHA put this in writing?
Yeah, I think we actually have a slide on that, right, Maria? If you want to go forward.
Give me a moment here.
Yeah. Dave, just real quickly before we jump into this about the differences in administrative requirements, I wanted to get your thoughts on defining meaningful progress based on your research. If there was anything because I think what we could adjust the language to say like accredited or the contractor has achieved meaningful progress that we evaluate on a case-by-case basis, and it's defined as in survey, has gone through these milestones with NCQA. I think that would be helpful for some predictability for CCOs. But I also think that we don't want to pigeonhole us into one specific situation just because in the beginning conversation, like if there's a bandwidth issue, if there's something that occurs, we want to have some flexibility. But do you have any thoughts on that definition or something that like milestones that we could put in there?
Yeah, I'm sure that there is better language that I would come up with a little bit more thought, but I think it's probably some kind of demonstration of meaningful progress of particular elements. So I'm just thinking about, the specific elements of requiring certain policies, procedures, data capturing processes. So it would be some kind of a way of documenting or attesting to or demonstrating that we've taken steps that would be evaluated in the accreditation. That would be where my mind would immediately go first.
So I would just add that I'm aware that you have to have everything, basically have all your ducks in a row, everything set up for 6 months before the NCQA process. You have to show them that's all in place for 6 months, and then they do an assessment. So to some extent, if we got through that thing, we're at the point where we're at the beginning of our 6 month waiting period or whatever, that feels like a potential because, it obviously, if we were ready today, we could start that 6 month period today, but I imagine a lot of CCOs are not there yet. They have not met all the requirements. And so something that's tied to, being getting to our side, getting the ducks in a row, as opposed to something that's tied to an NCQA thing, like being in the survey, because I feel like that relies on an outside entity, and I'm a little nervous about using that.
Can I make a clarification? I think that per my understanding, and I have a battery of questions for NCQA. I was waiting until I had the opportunity to meet with all of you to send those. When we reach the point of in-survey has a lot of weight. That means that you have a date, an official date, and that's where things are going to start to happen. Between now and the moment that you are on survey, there are multiple things, multiple instances that I know NCQA speaks about, and I don't know if perhaps Trillium or AMQA and even Yamhill would be able to speak about. There is a tool called the gap analysis that is shared by NCQA that we will have access to, that allows CCOs to do this exercise where they review where their gaps are so they can develop their work plans. And so, I think that knowing exactly what the process would be helpful for us so we can share the process as we understand it with all of you, perhaps organize a conversation within CQA so we all have more clarity on what it means to be under survey, the 6 months wait period. I'm not sure, I have not heard, but again, I have not talked about details within CQA. But I know that there are many things that can happen that require active work from the CCOs between now and officially on survey. It's a look, Nancy.
Thank you, Nancy.
Thank you, Nancy.
Yeah, I think getting the specific language of what we feel like the milestones feel meaningful from the CCO perspective in terms of the steps that NCQA define, I think is something that we still need to convert because we understand kind of the general process, but what are the words in terms of each of these milestones that we could put in contract? And then I think having some language to say, OHA will also review, a submission from the CCO to demonstrate meaningful progress, I think is fine. But I think just having some milestones would be helpful if we go with that change. Okay. And then back to the deliverable item, and then we'll get to hand raises. Maria, do you want to talk about the health equity plan, kind of the ending process for attached to NCQA?
Yeah, well, so the health equity plan generated a ton of heartburn when we decided to have it at the beginning of CCO 2.0. So this, we never meant to have the health equity plan to go longer than the 5 years because it was basically an opportunity for CCOs to show us their work around establishing their health equity infrastructure. So we don't feel like having the health equity plan be extended would be on the best interest of anybody. But we definitely want to close that chapter in all our lives by actually having CCOs develop a final report. And I think, I have shared with some of you what is the idea with the final report. We want to use some elements of the gap analysis that NCQA has developed. So all of you that will be actually using the gap analysis just to see your survey readiness can actually use some of those findings in your final report. We ask the CCOs to see if you were all happy to connect with us and join us in the design of that final health equity plan report. We want the report to be useful for all of you to document all the progress. So you look back at your 2020 health equity plan and see all the things that you were able to accomplish. What were the barriers you found? What were the promising practices, for instance? What are the things that you feel you were successful, and what are the areas you will be working on in the future? That's a very high level. But again, the goal is that to create a health equity plan final report template or outline with all of you, so it serves you as a tool to show your leadership and your members what you have accomplished. And it helps us as well as we move towards, CCO procurement, as we document your progress, as we share how much work has been taking place throughout this almost 6 years now. I think that is the goal with the final report. We don't want to leave it hanging, but the last year of the health equity plan officially, regardless of what happens, is 2026.
So, Nora, thank you for jumping in with your question earlier. So what I'd like to do is have Lucy ask their question because they've had their hand raised for a while, and then move back to the chat and then go to Doris.
Thank you so much. Good morning, everyone. Lucy Longoria with Health Share of Oregon. And just want to also reference Dr. Pusen-Mintz questions in the chat, but I'll summarize. Maria, I just really appreciate your efforts to check in with us as you're pursuing conversations with NCQA about this. I think most of my questions are you relate to your efforts, are you looking to, in this effort, negotiate or look for opportunities with NCQA to help them kind of understand Oregon's, healthcare transformation efforts and around the kind of the pursuit and culture of CCOs? Because I do think that the discretion that NCQA has around determining the path forward for how a CCO can even apply in terms of um, determining what qualifies as far as a network, or what is determined as far as the delegation, can make the cost very unpredictable, or what can be the scope and the scale of the efforts unpredictable as well, even before you're entering into the gap analysis. And so how well that reconciles with the existing health equity plan that a CCO may have can be, it can be a little tricky. And so I'm just wondering if there is some room in that negotiation for some even like economies of scale, for if they're expressing that they have the capacity to bring in all of the CCOs from Oregon into this process into a certain time frame. What is the kind of leverage that Oregon can actually get for this? And so I'm just kind of curious if you're seeing some opportunities that way as well.
Thank you, Lucy, and nice to see you. So let me start by saying NCQA is happy, willing, and ready to support this work. And they are thrilled to be able to do it, and they have been super accommodating and had been meeting with us, short meetings, because we didn't know exactly how we were going to proceed. So we have been trying to open the channels of communication. All I know is they're willing to work with us and support this journey every step of the way. Now, how does it look like? I don't know, but that's the reason why we wanted to have this conversation with all of you and have you, or at the very least, the health equity administrators be part of these conversations. So whatever we designed as an opportunity for CCOs meets your needs, and also so we can get NCQA help us get the work organized. I feel like we are really focusing on the survey part and the accreditation when there's like multiple opportunities before that to do some work, to have a level of understanding and technical assistance from NCQA as well. So what is clear to me though is that we will definitely take that into consideration, definitely will work on establishing something that makes sense and responds to the needs of the CCOs and our health systems transformations efforts, and that we want to do it in a collaborative way. So thank you for that.
Yeah, thank you so much, Mary. I appreciate that, because I do think that the that just the nature of the diversities of CCOs, I'm definitely thinking of those, it's the coordinated care organization and the real nature of multiple partners, multiple organizations, where we have these fantastic examples with like Yamhill and Trillium, where they are these contained, and forgive me if I'm using an inappropriate framing, or like contained, where you have other CCOs that are made up of multiple lines of business or partners. I'm thinking Eastern Oregon Health Share, all of these different partners where at least the existing structures for NCQA really does a much more siloed approach to measurement. And so while I do appreciate that real accountability to those specific outcomes across each of those entities, it can also undermine the unintentionally undermine the idea of that coordination and collaboration, which we would not want to have happen if we're truly trying to transform and help create a seamless, coordinated care environment for the actual people receiving care. And so I would hate for that to take place at the the intended idea of trying to get this great standards in place, the foundation of a standard.
Yeah.
When we're actually undoing what Oregon is trying to do with transforming care through coordinated care. So I just would love for us to make sure that we're not, throwing out the baby with the bathwater by trying to get this much more streamlined accountability measure, but actually undermining that work. So I hope we're bringing that kind of strategic lens to it as well, and not just looking at the more fine-tuned administrative burden release. So thank you so much, Maria. I'm happy to continue supporting thinking about that strategy.
Just I'll just one comment, because we did talk to NCQA a little bit about the uniqueness of subcontractors in the CCO model when we first met with them. One thing that we have kind of at our back is they are working with all kinds of different flavors of insurance companies and other markets across the nation, and they didn't seem to be concerned about some of that interrelated, different risk-bearing entity kind of thing. At least when we talk to them. I do think as you guys get into it and as you start evaluating pieces, it is important that you're including your boards and the individuals that govern these subcontractors and making sure that they understand, where this connects to existing work that was related to the health equity plan and how it is kind of that evolution. Communicating to your subcontractors the intention and what is going on, I think, is really important. And then also, reporting back to us on how those conversations are going. I know we're happy to be part of any conversations with NCQA. If there's something we can help explain and how the CCOs are created or how they've been kind of allowed to be very different, because I do think that that's challenging, looking at it from an external perspective. And we've had to do that with a variety of contractors, for sure. So I just really appreciate that comment, something to be mindful of. I think that they're understanding that they're excited to get Oregon on board. They did not seem to be concerned about a lot of involvement with subcontractors, is really my bottom line there. I do have a hand. Do you want to go to that? Oh, maybe I'll try to see who that is.
Actually, Chelsea, I was hoping to go to Dr. Mint's comments in the chat as a follow-up to what Lucy was discussing for health share. So can you take a look at those 2 points? Anything in there we can respond to now, or is it a
I'm
take
sorry,
back
I'm
and
not
research?
seeing it. Where is it?
It is
you read
just
it?
under Josh's comment.
Oh.
How familiar is OHA with the entity designation process with NCQA as it pertains to non-traditional, coordinated, or transforming health systems, and how that could facilitate or impede those transformation efforts? And then the second item.
I think Lucy did a great job referencing that in her question, at least the first question. But I think the second one in particular is a little bit more about the complexity of the health share model and just, our members and just making sure we're thoughtful about how we're able to manage that duplication. So it gets a little bit more technical. And if you're not ready to respond to that today, we understand. We're looking forward to more technical assistance support from OHA.
I think this question might be really good to lift off and give to NCQA. Maria, I think that if you guys have more of these technical questions, I think that would be a really good work going forward and how we can define things, potentially in the contract or in guidance. I think we can always put some guidance onto this contract change also, and that guidance could potentially be where some of these technical pieces could be addressed, if we get different different changes. I know that Cheryl's nodding vigorously,
Mhm.
knowing that keeping things maybe simple in contract and referencing guidance might be more flexible for our administration of this. So appreciate that. Go ahead, Maria.
Chelsea, just a couple of things. So thank you. I welcome this kind of technical questions that are very like CCO specific. We try to pose questions that I think we had received throughout last year and this year to them. They have been very useful in the sense for us to understand how this process works. But all these technical questions, you don't need to submit them like today or Monday, but the more specific your questions, the better for us to design within CQA a system and or answers for a potential presentation. We remember we had a presentation last year for NCQA, a couple of them. They are ready and willing to do it again and again and again and as many times as necessary. So these are the type of questions that I think would be very useful for us to have. And so the sooner that you can send those to us, the better. Again, I have a battery of questions already that I will be sending this afternoon to them, but send them our way, and we will be happy to actually get NCQA to answer those if they're able to, of course.
So I want to acknowledge that Doris has had their hand raised for a very long time. And so I'd be glad for Maria and Chelsea to start skimming the other comments and see which ones might warrant a response after Doris finally takes the stage.
Good morning, everyone. Thank you. I wanted to add something that Dave said. I know he spoke a while ago and some folks may have forgotten, but making the deadline for 2026, it would also be helpful if instead of just looking at if a CCO has an initial survey date, is if a CCO has purchased the survey. I am the equity policy analyst at Advanced Health. We purchased the survey. We did not purchase the survey date because of the look back periods. Some elements have look back periods of 6 months, others 12 months, and there is one that has a 36-month look back period. And so as a CCO, we said, okay, let's get our ducks in a row. And after we've compiled everything, we'll reach out to NCQA and give them our survey date, quote unquote, purchase our survey date. So I think just having the NCQA in position for CCO to have it in position, that is also a step to accreditation, not necessarily just having the initial survey date.
That's great. So I just want to make sure I'm capturing it. It's a look back period purchase. Is that the language?
No, each element has look back periods of
Oh,
the
survey
NCQ
purchase. Sorry, that's what you said, right?
Yes, yeah.
Okay. And we'll run this language by NCQA too to make sure it matches their understanding of their milestone pieces. The thing that I'd like to find in contract is meaningful progress that can be verified by NCQA easily. And then I think if there's some gray area where we have to kind of work with the CCO, we can always allow that too. But it would be easier for you to just say, here's where we're at NCQA. NCQA says, yes, we are, and then we move forward. So survey purchase. I'm writing that down. Thank you.
Thank you.
So anything else in the chat you want to dive into before we have Dominique on?
Just one clarification for Josh. So your struggle is with the interpretation of meaningful progress. That's what you want clarification?
No, I just think it's one of these things where we don't want, or I just struggle having in the contract flexibility and interpretation as part of the contract. To me, it would be much more simple if we said, hey, continue working this direction. We will change the contract in 2027, 2028 once this is operative. But I don't think it is universal. It's not just this issue. It's any issue where it's, hey, we're going to put this in the contract, but we'll have exceptions, and OHA will make a decision if we like it or not. It just it complicates future planning, and I think it's a bad precedent in general. It's not about this issue.
Okay, so if I understood you correctly, you want us also to make sure that our exception process is clearly stated. I'm only worried about this part. I'm not worrying about other sections of the contract or all the contract for that matter. So in the case of NCQA health equity accreditation, if there is a process for exemptions, you want those to be clearly stated in the contract without so you don't have to interpret those. You want us to be very prescriptive then.
I find, yes, I think the contract needs to be clear.
Okay, got it.
Not
Thanks.
not subject to interpretation, because none of us, somebody might win the lottery, move to Bermuda, so things that are said here aren't necessarily going to get transferred. So I think it's important that we are abundantly clear of what the process is, which is, I think, important.
Got it. I play the Powerball as often as I can, but I still finish this through even if I win it. You have my commitment. I will not move to Bermuda until I get this through.
So do you think we're ready?
We can take that in. I think what I was leaning towards is defining specific things that would for sure pass the like meaningful progress thing, and then having an open-ended option, but we can also just make it so it's just milestones and no open-ended option too. I'd like people's opinions on that and how we define meaningful progress. And then there's a hand still up too, Cheryl.
Yeah, Dominique. Thanks for being so
Yeah,
patient.
thank
Dominique.
you. I had a question or a comment. I think it was on the other slide regarding the 2026, the final health equity plan report. Because for 2025, CCOs were given the option to send in an administrative notice to OHA to request a full or partial waive of the health equity plan submission for 25. If they were in process with a accreditation or already accredited, and just want to keep that in mind with any requirements around a 2026 final health equity plan report. And just want to call out, for CCOs who do have that in place by these due dates for 2026, if the final health equity plan submission in 26 will be a requirement, or if there will be an alternate or complementary approach if a CCO already has the accreditation.
Hey, Dominic, I think I think there's like a couple of slides. All CCOs will have to complete the final health equity report, all of them. And we are going to make it the least complicated thing that you have ever worked, but all of them have to close that chapter, regardless of either you are under survey or accredited. For that reason, we have changed the submission deadlines. So we are talking about if you are accredited, you have to submit your final report in September. And if you're not accredited, you get to resubmit it in November, because we figure it's going to take longer. You're probably on gap analysis or doing other things, just trying to get ready. So we don't want to overwhelm you. So the final report is for all of the CCOs, regardless of their survey status. For 2025, though, yesterday was the deadline for CCOs to share with us if they were officially under survey or already accredited, and you are already accredited. So we have 2 CCOs already accredited and 1 that is officially under survey with survey date. We are, because we were waiting to see how many of them were going to be, we just have to modify a couple of things we have put into a memo and just submit those the areas that we are going to waive to Medicaid leadership for approval. And once that's done, then we will be communicating with all 3 of you what are the elements that will be waived and what are the elements that will not be waived. So you should be looking for that memo to come sooner rather than later. I'm not sure exactly how long it will take for Medicaid leadership to approve that memo. We will adjust dates accordingly based on our deadlines, and I think 30, 60 days. So yeah, bottom line, all have to do the final report. All those are accredited or under survey right now will receive a memo with the elements that are waived and the elements that are not waived. Soon.
Great. Thank you for the clarification.
No problem.
I'll just,
So,
throw out
please go ahead,
the
sorry.
fact that getting feedback on what you think is outside of like what is covered by accreditation or what it should be waived or not waived in that final report, I think would be really helpful. We also want to emphasize that this report isn't just about that annual kind of plan. It's really about looking over the whole contract period and all the progress that's occurred. I think that's a piece that Maria mentioned, but I just want to emphasize that like the final report is in a way a capstone on us getting there to the point where we're at. And I think will be a really helpful item to look back on, and probably will be pulled from all the other reports and your work with NCQA into one document. So hopefully not too much additional work, but I think it's also really helpful for us to have something that looks at lessons learned, what we did, what we could do better in the future as we continue to work in health equity and build off of this foundation.
One last thing, just because I'm scanning the questions regards to staffing. I am not going to make comments around staffing. I'm not sure how you operate and if you have to engage with someone or not. But one thing I want to be very clear, though, that the whole technical assistance and educational support that we are planning on designing and we're currently designing with support of NCQA has been because we do have really clear in our minds that all CCOs are different. There are some large and some small ones, and that's the reason why we're doing this. If you go, we have had conversation with NCQA. There's around 30 states that have this requirement around NCQA health equity aggregation for their managed care plans. I think of the 32 of them have had some level of involvement of the state in the process. I think we are an exception. We want to see you successful, and that's why we are going to be supporting you every step of the way. So I just want to make sure that you understand we are very mindful of those of you who belong to a small CCOs where this could be challenging, and that's why we are building all this system of support so you're successful.
So I want to take a quick moment, since there's been discussion of the technical assistance and some of Josh's comments about the specificity in the contract versus guidance. So I put in the chat a link to Director Hoppy's memo that represents OHA's commitments to improving the process for the restatement activities we do each year. And one of those items specifically says, if there is implementation guidance needed for a significant contract change, OHA has to provide that to CCOs 90 days in advance. So anything that might go in the contract to be effective 1/1, that means October. If it's a later effective date signaled in the contract, then it's going to be 90 days before that effective date. So I've been making this point clearly to all of our internal folks who have proposed significant changes so that they understand that if their proposed change is ultimately approved by leadership, they very quickly have to pivot to implementation planning. And so a lot of the questions that have come up today will lead directly to that implementation planning and what needs to be covered in that implementation guidance. So Chelsea and Maria, I'm looking at the chat. We've had lots of additional comments. I'm looking for specific questions. So a question from Mark Lewis about, has it been determined how this work will impact the 26 rates? Somewhat related, Josh's question about how much does NCQA charge per CCO for certification? So if you guys could take a look at those questions, and I would like us to move on in the next few minutes so we can get to the NEMT item. I'm sorry, the share item next. I'm sorry, NEMT, I was right the first time.
In
they'll-
regards to how
yeah.
much NCQA charges, I don't think it's our role to ask that question. So I invite you to connect with NCQA and ask those questions. We will make sure that we do have an understanding on or how much the process is, of course. But I think those are the type of questions that you need to ask NCQA as a CCO.
We don't want to
That's my
quote.
only
We don't want to quote numbers for sure. Agree
Yeah.
with that, Maria. I think
Yeah.
generally the accreditation is not very costly, but the work related to getting it is the more costly piece. Some CCOs have quoted to us the consulting fees that would be involved or the manpower that would be needed. Some CCOs have been focused on more of a consultant help, just because it is getting across that finish line and what that would cost. We did price it out at the Mercer level last year. Welcome you guys if there's updated pricing or information you have for 26. We will be happy to take that as part of the rate setting process. So just wanted to throw that out there that your review and assessment is really important. And I do think moving forward, we have to make the conversation. That's why I'm here, right? That we have to make the conversation also about the financial impact and moving that. So go ahead, Nora.
I really appreciate that, Chelsea, because you're absolutely right that the actual cost from NCQA is one thing. It's, several $100,000. It's not insignificant, but when we went to consultants to ask about the cost, it was over $500,000 per. And for us, for Care Oregon, that is more than one, obviously, because we would get accredited at the CCO level. They don't let us get accredited at the Care Oregon level. And then the significant lift for staff. And I know that that Dave's team and others have looked at not just the cost, but what's the impact on the work that we do now and how we prioritize. So I really appreciate efforts to have the rates reflect not just the fee from NCQA, but the costs associated with staffing and consulting time, because that's really where the impact is. So thanks.
Apologies, I was on mute. So Josh, we're going to go with you and then we're going to wrap it up.
I just wanted to say I think it's important that when Maria and Chelsea read the whole thing that I put in there, because the comment really isn't just about cost, it's about the willingness of NCQA to understand the uniqueness of Oregon. And that if you guys are having conversations where they're like, yeah, sure, no problem, we'll understand that. I think it's really important that you guys get that in writing so that we and it's part of the guidance that's coming so that we understand kind of where that's at, because Oregon is odd. We're just, we are unique, and it's that uniqueness has allowed us to do a lot of really great things across the, and really be the leaders in the state in the nation. So I just want to make sure that those conversations are getting translated in writing back to us so that that guidance is incredibly clear and that we aren't losing something in getting lost in translation. And I also think that the other piece is this is just my experience, maybe it's my bias, but I have spoken to a lot of vendors who will promise you the earth and moon and stars when you first show up. But man, you sign that contract or you make a rule change or you do something along those lines, and all of a sudden those flexibilities go away pretty quick. So I think it's very important. That's why you want to do that first part, get stuff in writing, make it part of the guidance so that we're not getting burned later.
Agreed. I'm just gonna put a fine point on what you just said, Josh. I think one of the things that would be really helpful for us is to highlight what you think are going to be the uniqueness challenges for the CCO model. I hear a lot of things related to subcontractors and their accreditation, kind of downstream policy pieces in this conversation, but I want to make sure we're explicitly talking about what NCQA needs to be ready for in how it's evaluating Oregon. So if you have any of those items in writing, I think that will help us get better guidance in writing as well. And I think, just highlighting this piece, we did talk about it on Tuesday, but having technical assistance in learning collaboratives on this item will hopefully improve our ability to both interface as an agency with NCQA while you're interfacing with them as well, and really moving that forward. So yeah, appreciate all of that in these pieces. I think this is really, really helpful. And I think this is just being or supporting the fact that we need TA and a learning collaborative that Maria already is planning, and I think is going to be really helpful to move this forward and potentially, and I say this only because there's a really, really strong connection to our health equity plan, potentially make NCQA's health equity accreditation better and improve it in the future too, because they seem to have used a lot of our pieces in theirs as well. So Maria, did you have anything you wanted to add on that? Do you want to give a deadline for feedback for us sending it to NCQA? I know you have a batch going out today, but I'm just wondering if we can ask them, the CCOs generally, if we wanted to give a future deadline for another question round. What do you think?
Yeah, I mean, what we can do is like I'll send my batch of questions. Let's say that I will be sending batches of questions every Friday during the month of May. So, if you can send me questions before the Friday of that week would be great. And then after May, I will not be sending anything else because they're probably going to be sick of it. So yeah, send me the questions, please, so I can actually pull all of them and send just one email to them every Friday from now until the end of May.
Thank you all so much, Maria and Chelsea. I know this is a lot to do on the fly, but that's the whole purpose of this forum, is to have kind of a stream of consciousness, open conversation. And thank you, Josh, too, for a lot of your in the weeds questions, and everyone else as well. And just please know that we are not done with this topic just by the fact that this is the final office hours. There is a lot of conversation still to be had on this. So I want to acknowledge that we're now going to move on to the NEMT item. And so I believe I saw Rachel Manley on the chat, and I don't think I saw Michelle. So
yes, it will just be me today, Cheryl.
Perfect.
Yeah.
So why don't you introduce yourself real quick?
Yeah. Hi, all. For those who I didn't get to have the pleasure of meeting in our contract conversation, my name is Rachel Manley. I am the lead operations and policy analyst for NEMT fee-for-service and CCO. I'm just rounding my second month in here, but with OHA specifically, but I've had about 8 to 9 years experience within NEMT, working for brokerages and also working for care plans to support this. So not totally new to NEMT, so definitely can be able to field quite a few questions, but new for OHA, and happy to be here.
Thank you so much, Rachel.
My name is Maria Cristina Gonzalez Kress. I use she and they pronouns. I am on the transportation team along with Rachel. I'll be taking notes, what we got in the chat, what we say verbally, and here to support Rachel in any way. Thank you.
Thank you, Maria. So I'd be glad for folks to raise their hands. And so same as before, I'll be trying to flag for hand raises and also to monitor the chat. And there must be questions because in the faulty poll,
we were pretty popular in the poll.
And number 2 in the hand raises.
I will say they're pretty minor changes. So, hopefully folks don't see them as anything administratively burdensome coming up for 2026 contract changes. But yes, please, any questions, comments, thoughts on these 3 changes that are occurring? I will say the final one, though, to align the 45 seconds for live voice, that is just to align the contract verbiage with what is already in process at this time. So that one shouldn't be a huge change as well.
So I'm looking at Dana's comment in the chat. So Dana, so that the reference to the communication devices, that was in the sort of sneak peek that we sent to the CCOs before the process officially got underway. That has since been removed from the proposal that's currently moving forward.
Thanks, Cheryl.
A question from Anna Warner, will we be able to receive the updated member reimbursement rates prior to the submission deadline?
We have not included that yet. I will definitely follow up with the team to identify if that is something that we're going to be moving forward with. And I can respond back in our notes too if there's any additional questions that we need to get back to folks for. But thank you for asking, Anna.
And I wonder if perhaps the apparent interest was because of that sneak preview that referenced the communication devices. Yeah.
Yeah, that's going to be a lot of work going forward for sure.
Yeah. Well, so if there's no imminent hand raise, we will actually move on to the share item.
All right, well, I'll put my email in the chat too, even though I know it's on the slide deck as well, in case anyone has any other questions that come up or comments as well regarding these changes that are proposed here. Oh, Josh, go ahead.
Accidental. I was trying to give a thumbs up, so I was just going to say thank you so much.
You're welcome.
Well, thank you, Maria. Oh, hey, Jill. Yes. Saved by the bell.
This isn't really about the actual changes. I was just going to ask if there's any chance that OHA will be doing similar to the handbook, something for the writer guide in the future where we could use the template and everybody's looks the same, like we did on the writer, like we did on the handbook. Or if maybe we could somehow add the information. We have our separate, we don't have it in the handbook because we use the OHA version, but it would be great if, I guess all the information could be in one place for members. I haven't had one member ask me for the writer guide.
Well, Jill, thank you for bringing that. You're very timely. Actually, that was a conversation I literally just had yesterday. So that is something that we're planning on moving forward with as well. So I'm going to be working on that pretty soon, actually.
Great. Thank you so much.
Yeah, you're welcome.
And Jesse. Jesse, do you have a question or comment?
I'm just talking away. So sorry. If we are going to have a guideline to use or a template to use, is that going to be available well in advance before our due dates of September through October?
Yes, absolutely.
Because we're sending it in sooner rather than later, will we get it back in order to post it in a timely fashion?
Absolutely.
Okay, thank you.
Hey, this is Maria. I have a quick question for you. What do you consider a reasonable timeline for that? Was that, I'm sorry, who was speaking?
That was Jesse.
Oh.
Jesse.
Well, to get the template,
yeah,
the sooner the better. I like to work on it so I'm not like doing it the last minute, and
absolutely
then just making the changes as they come along, because they do. They come along, and especially like with the rates. I think that was the holdup last year. Was we were all waiting for the rates to come through so we could update the writer guide, and they came in like last minute. So
yeah, cool.
It'd be nice to have pretty much everything and then be able to kind of fill in the blanks if there are any changes at the last minute.
Absolutely.
Which we will try so hard and diligently not have happen this year for you.
Perfect. Thank you.
You're welcome.
Well, great. So thank you both, Rachel and Maria. And now we're going to move on to another Rachel. And so if we have Rachel Burden, and I believe we have Alyssa as well, and I don't see Laura, but we're going to move on to the share item now. And I have the proposed change on the screen, and I want to acknowledge too that these changes are consistent with the memo published for CCOs last December that was the result of the shared work between OHA and the director's office and the governor's office about changes to share. And I'm happy to put that link in the chat in a moment. So my OHA colleagues, if you want to introduce yourselves real quick for the share item.
Yeah, Cheryl, hi, and hello, everyone. Rachel Burden, she, her, and I'm the Social Determinants of Health Policy Advisor and Health Policy and Analytics. I'm happy to be here today to hear input and questions about the contract changes to share. I'm joined by my partner in share, Laura. Laura, I don't know if you want to introduce yourself too. Please do if you'd like. And then a couple other folks who can be on hand to answer questions that might come up.
Hello, happy to be here.
So Cheryl, yeah, I think we're ready.
Perfect, thank you. So I'd be glad for folks to start raising their hands or putting questions or comments in the chat. And I did just insert the link as well to that memo from December that I referenced. I'm gonna, oh, hey, yes, Jacob.
Morning, everyone. I seem to have it in my head that a previous version of the description contained a or read to me as like an additional domain for an eligible share expense. Is that correct? And is that still the case, or is that evolved, or am I just not? Am I missing it here now?
No, Jacob, you've got that right. That additional domain, however, that change is happening through a separate process, not this contract process. That is happening through rule, because those domains, which are 4 right now, but we're adding a 5th one of healthcare access and quality, that's in rule. So we're making that change in rule. So again, like today's process is about the contract changes. Happy to hear if you want to say something about that domain, but it's not part of this contract change process.
Okay, those, because the eligible domains are not contained in the contract, is that?
Well, the base from where they happen is in rule, so that change is happening in rule. And I will say that public comment, I mean, we had a rules advisory committee. You may or may not have been there. I can't remember, but public comment is still open on that.
Mm-hmm. That's why I read it. Yep, you're right. Okay, fair enough. Thank you for clarifying that. Yep.
Yeah, so just encourage you to, if you have questions about that, to please still communicate with us. And like the public comment period process is probably the best way to do that.
Thanks, Jacob. Any other hand raises? I'm not seeing anything in the chat yet either.
Right, it might be helpful, just given kind of that question about the domain, that there are, right, some changes happening via the rules process, and then some are happening through this CCO contract significant change process. And so the slide that Cheryl is sharing now are those changes that came out of the governor's office convenings that are changes through contract.
And I want to note with that in mind that as Rachel already alluded to, the engagement process for rule changes is through that rulemaking process. And then for content that is solely living in the contract, this restatement process is the engagement mechanism. And rule takes precedent over contract, so that's why they're sort of separate processes and also on separate timeframes. So I'm not seeing any more hands. And nothing in the chat. So unless there's an imminent hand raised, we are going to move on to the BHP item. And I'm pretty sure I saw Tim.
Yeah, I'm here.
Okay, so why don't you introduce yourself real quick, and I'll move the slide in just a moment.
Sure. I'm Tim Sweeney. I'm in the Office of Health Policy in HPA at OHA, and I'm the policy lead for OHP Bridge, our basic health program. And this, we did not get any questions when we presented this before, so hopefully the questions are relatively simple. But the proposed change is just to add reporting requirements that exist for the Medicaid contract back into the BHP contract, with the exception of requirements specifically tied to the quality incentive program, which is not part of the BHP.
Thanks, Tim. So any questions or comments? Looking for hand raises and monitoring the chat. And we should at least ask Tim something because he's been on the call now for over an hour. So let's ask him something.
I will not be offended if people don't actually have questions.
Audrey.
Oh, there we go.
So what would this look like for quality deliverables? Would we report out Bridge and Medicaid separately or just all together?
When you, I guess to the extent that I think there's some flexibility there, to be honest. I think, in seeing one of the questions in here, there's not member level data. So that's not something that we would expect to be reported separately. I think, I think that would be an area where we would be interested in the CCO feedback to note if there's barriers to reporting separately. I mean, the idea is to piggyback on the same reporting structure, similarly to how we have reporting set up for other things, like, for example, the reports for Exhibit L. But we want to make sure that the data is there. So if it is simple to separate it out or to have indicators for different pieces, that would be great. If that adds a ton of complexity, then that's certainly something we'd want to better understand.
Well, and I want to acknowledge also that Tim will be working closely with, for example, Lisa Bowie and others involved in the quality space to talk about the TQS and the PIPs. Our approach is that for the non-Medicaid and BHP contracts, any content specific to either of those contracts that is part of an overall deliverable, we would only ask to call out or somehow have responses specific to either of those contracts if there's a business reason to have that called out. Otherwise, when a CCO submits a deliverable, if that deliverable lives in all three contracts or even just two, what's submitted is presumed to represent both contracts without a specific call out. So again, we'd be focusing on the business reason why, for example, BHP must be called out specifically in the TQS or in the PIP. And so that would involve a specific conversation with our colleagues in HPA.
There's not an underlying, I guess, to sort of follow up to that, there's not like an underlying, yes, we have to have all this stuff separately, right? Like, I think the intent is to broadly make sure that reporting is inclusive of the bridge program. And so if that is helpful.
So Tim, I'm looking in the chat and there's some questions for you. So looks like Lancelot Sparhawk. So why don't you take a look at that?
I guess I would feel like I need more information to really understand this question around the ECQM, because I'm not as familiar with that
CCO
piece.
incentive measure set. Every year we have a certain series of incentive measures that we report data up to OHA for. And there are several of them that are EHR based measures. Those measures are generally not able to be stratified by EHR vendors down to the payer level. So additional queries have to be run to split them out by payer, et cetera. So just wondering what the structure of that would look like, since it is specifically called out in the measure specifications for the CCO incentive measures to exclude the BHP members from reporting.
I mean, I guess I would be curious how that's done currently. I mean, the intent is that we're continuing not to ask for reporting of BHP members for incentive measures, and I think that that's similar to my understanding as to how Healthy Oregon members are treated. Is that that's a Medicaid measure, and so there's some different call outs there. If there's sort of some new issues, if there's broader issues sort of like separate from this contract change that are related to how data is reported for the incentive measures, I think that that would be something I would want to make sure that the folks working on the incentive metrics program are part of that conversation, because it sounds like that's a bigger question than related to this change.
So I wonder if maybe this needs to be taken offline because it's pretty in the weeds.
Yeah, it's very specific to electronic health measures, so it's probably something that would need to be addressed by the technical specialists.
Indeed, yeah, because I just want to confirm that this specific contract exhibit is essentially bringing the content into the BHP contract, except for anything related to the metrics program, the quality measures. Those would continue to not be in the BHP contract.
Yeah, because currently they're excluded from the measure reporting.
Exactly.
Yeah. And that's, so we would intend for that to stay the same if it's related to the reporting for the incentive measures.
Yeah, and that's why it gets complicated, is a lot of EHR vendors cannot parse out that data on a member level based on the payer. So when they provide us with their summary data, there's no way of knowing who of the population is specific to BHP. It could be, that it's just all members under the umbrella of Umpqua Health, or some EHRs can't even break it out by payer. So you're getting, general data for their entire populace, not even just Medicaid. So again, probably something to offline.
Yeah.
Yeah.
So I'm looking at the other comments in the chat here, Tim. So we have Anna's question, but then we have Dave's response, which is really the existing Medicaid contract-based deliverables. Those, when those are submitted, those are intended to cover all the contracts. And so we really don't expect changes to the BHP related deliverables. And so this is a required change, correct, Tim, because of federal expectations for BHP?
Yes. Our federal reporting. Sorry, never mind.
Please. No, please go ahead.
I was just going to say our federal reporting includes just some language around ensuring that the state is monitoring quality, and the requirements in the Medicaid space would be sufficient. And so it's largely making sure that we are capturing the BHP data in that information.
Thank you for that. So any further questions or comments about this topic? And Tim, would you mind putting your email in the chat so that Lancelot could send a follow-up email with some of the specific details so we could better understand exactly what the issue is? And so not seeing any other hand raises, no questions in the chat. We're going to do going once, going twice. Oh, thanks, Rachel. And if there's nothing else, I would like to very much thank you all for your time today, this hour-and-a-half session, and for your engagement in the previous 3 sessions. And like I mentioned at the beginning, we will be asking for feedback on this overall process so we can look to make improvements for the 27 restatement process if that is what comes to pass as a result of HB 2205. And with that, I wish you all a good rest of your Friday and a happy weekend. Thank you so much for your attention today.
Thank you.
Thanks, Cheryl. Appreciate it.
Thank you.
Thank you.